Okay, today we get to spend a couple of hours talking about diabetic emergencies, a little bit of hyperkalemia. Of course, true to form, I had Mark set up at least an hour and a half of basic science first. No. No, I could do all sorts of things to you guys, but not that on a... This is a little... Is this too loud? Okay. All right. I think we can get one of the back lights, or one of the... Get the front light if you can, John. Okay, good. Let's see if my machine works here. Oh, yes. Okay. Okay. So, diabetes, we got to talk a little bit about the endocrine system, and not that fast, perhaps. Endocrine system works by producing hormones. Hormones are chemicals that affect other glands or body systems. This is Mark's comment. Hormones also affect your ability to think with any clarity at all, but I won't claim that one. Now, the endocrine hormones are released directly into the blood and then transported to the target tissue. Exocrine glands transport hormones to target tissue via ducts. Now, a simple exocrine gland is a sweat gland. You wouldn't ordinarily think that it's transmitting hormones, but there are some hormones in sweat exocrine tissue. The pancreas, the endocrine pancreas, it's retroperitoneal between the spleen and the duodenum, and it has the endocrine portion produces from the islets of Langerhans. Langerhans was an anatomist, described these things, little cells that are arranged in clumps called islets. Alpha cells produce glucagon hormone released into the blood. Beta cells produce insulin released into the bloodstream, and delta cells produce somatostatin and gastrin, which is also released in the blood. And gastrin affects the stomach, affects your, controls hunger, etc. Now, there are exocrine cells, too, that are secreting pancreatic enzymes that go down the ducts, the pancreatic ducts, excreted out through the common duct and wash into the food to help to digest fats, proteins, etc. Well, I think I need a new battery or something, and this thing is not clicking ahead very well. Okay, we'll just do it this way. Now, why are we going to talk about the... Went two. Why are we going to talk about the adrenal glands now? Well, because the adrenal glands are intimately associated with diabetes, because they also affect the control of sugar. Adrenal glands are retroperitoneal also, superior to each kidney, sort of pyramidal shape. The adrenal cortex produces glucocorticoids, hence glucose. They have to do with glucose control. Mineralocorticoids, which deal with salts, sodium, potassium, etc. And also androgens and estrogens, which deal with whatever it's going to deal with. The adrenal medulla, the inside, produces epinephrine and norepinephrine. Okay, diabetes. A Greek word meaning passing through or siphon. What's passing through it? Well, glucose is passing through into the kidney. Remember, the first notice that they had that there was such a thing involving diabetes, or that diabetes was a thing, was the observation that persons who had this condition had, among other things, sweet urine, i.e. the sugar was passing through. Now, remember, there's a good description in Samuel Pepys' diary of the early 1500s in England. He was a contemporary of Ben Jonson and a few other people, and he wrote. One of the things he did was he was writing about physicians at the time, and he noted that physicians would diagnose diabetes by tasting the patient's urine if it was sweet. Now, that's how or why we invented lab techs, so they could taste the urine. So, diabetes mellitus is a group of metabolic diseases characterized by high blood sugar levels. It results from a defect in insulin secretion or the action of insulin. In other words, the insulin that's produced may not work correctly, or both conditions can occur. You don't produce enough insulin, and the insulin you produce is bad. It doesn't work right. Now, there's a term gestational diabetes, which is increased blood sugar during pregnancy. That does not mean that the person has diabetes, although there's a slight propensity to have type 2 diabetes if you had gestational diabetes. But during pregnancy, particularly the last term of pregnancy, there's a tremendous amount of hormones produced from the placenta as well as from the adrenal, which affects glucose metabolism. So the blood sugar rises. That's not particularly good for the baby. Get large, heavy babies difficult and kind of lazy when they're born. Diabetes insipidus has nothing to do with diabetes. There's no sugar issue here. This is the inability of the kidney to conserve water, and it's basically a function of the pituitary gland and its control through hormones over the kidney, and you cannot maintain water. So you pass through water in this case, hence diabetes, passing through. Okay. All right. Glucose, dextrose, same word, same thing. Glucose is the primary energy source for the body. It is ingested in its primary form or converted from dietary sources. Dietary sources besides glucose include fructose and all sorts of other sugars, and then through gluconeogenesis in the liver, your body will, under correct situations, including adequate amounts of insulin, your body will produce glucose from proteins, fats, etc. Glucose cannot diffuse through cell walls without assistance. It's a big, funny compound, but cell walls have glucose transport mechanism, glucose transport proteins, which bind to the carbohydrate, pass it through, to bring it through the cell membrane. It says these are located throughout all cells of the body. Not true. There's a mistake on this one. They're not. They don't occur in red blood cells, and they don't occur in brain cells. You don't have a glucose transport mechanism. Now, a coupled reaction is a chemical reaction that occurs when a specific organ system, it allows the organ system to complete its entire. So, coupled reaction is what happens in your normal cell functioning under adequate oxygen, adequate glucose, adequate glucose internally. So glucose first goes through a small amount of, well, I'll go to one slide here. Free energy is the amount of energy released by the complete oxidation of a food substance. Now, carbohydrate, when you eat carbohydrates, mostly it's 80% glucose, and then there's some fructose, some galactose. Your liver converts the fructose and galactose to glucose, and it does that by adding some ATP to it, a phosphorylation step. So that takes some energy. So it takes, that's why the, you know, diet, people who are into dieting say that, oh, you should eat natural sugars like fructose, galactose, because it takes energy to produce glucose from that. And so you don't get the same amount if you just eat straight glucose. You're not going to have to use that energy to burn that energy, to produce the energy. So that's why most diets would have you avoid pure sugar or pure glucose and go to fructoses and other things. Now, glucose is transported across the cell membrane through facilitated diffusion. There's the protein that it hooks to. The glucose, it's a glucose carrier protein. Hooks to the carbohydrate, carries the glucose into the inside of the cell. That is facilitated by insulin. Insulin is nothing more than a facilitated, sort of increases that reaction of the protein, carrier protein hooking to the glucose. That's about 10 times, makes it about 10 times more efficient than if you don't have glucose. Otherwise, the only way you can get glucose into the cell is to increase the amount of glucose outside the cell, and just by simple, you know, huge amounts of glucose outside the cell, that'll force the carrier protein to pick it up and bring it in. So it becomes just an osmotic thing, a diffusion kind of thing. When it gets into the cell, glucose is broken down by a process called glycolysis into 4 distinct molecules. That releases 2 ATP units of energy. If you have adequate oxygen and the cell is functioning normally, it then goes through the Krebs cycle. You've seen those pictures, the little circle thing, where these 4 molecules go a further step down to a pyruvate, and that produces 2 more ATPs. The next thing that it goes through on normal, you have enough oxygen and you have insulin present. It goes through oxidative phosphorylation, which takes that oxygen, combines phosphates with this pyruvate, fully breaks it down to carbon dioxide and water, releasing 34 ATPs, which is a huge energy thing. I mean, that's where where all the energy comes from, is from that oxidative phosphorylation, and it requires the presence of insulin to kick that part going too. Probably because it requires insulin to get the glucose into the mitochondria, because it sort of gets into the cell, but then if it can't get into the mitochondria, it doesn't work right. Now, so if you just stop at glycolysis, only 2 ATPs. That's what happens when you don't have enough, when someone is in shock and you don't have enough oxygen getting to tissue. It stops at either glycolysis or it stops at the Krebs cycle. And when you don't have enough insulin, i.e. a severe diabetic, and you have a lot of sugar, high level of sugar on the outside, then you get into diabetic ketoacidosis, because you're not producing energy, and and the cell has to go to fats to produce energy. breakdown of fats, because that goes through a different process. Now, gluconeogenesis is the formation of glucose from glycerol and amino acids, fats, and proteins, and you can make your own glucose. The liver does that. It's regulated by low blood glucose, decreased carbohydrate stores, so the liver begins to process glycerol and amino acids and producing glucose from that. That also depends on the release of cortisol from the adrenal cortex. We're back to the adrenal gland, why we talk about the adrenal along with diabetes. And then it also mobilizes amino acids. Where does it get amino acids? It steals them from the proteins of your muscles. That's why undiagnosed diabetics, and sometimes even diagnosed who are very brittle, who have long episodes of high glucose, low glucose, but glucose isn't getting into their cells, so they're wanting to make more glucose, steals from the protein. That's why they have muscle wasting. Okay. So insulin is produced in the pancreas by the beta cells of the islets. It activates the transport proteins located in 2/3 of the body cell. Remember, not in the brain and not in the red blood cell. Mostly skeletal muscle and the adipose tissue. You have to have adequate insulin in order to put fats down, to store excess glucose as fats. It's a hormone, binds with the muscle adipose cell membrane, muscle and adipose cell membrane receptors, increases permeability of glucose. The half-life of insulin is about 6 minutes. So if you get 2 units of insulin burst, it only lasts for 6 minutes. That's why we found out that, long ago, that if we had somebody who was in severe diabetic crisis, blood glucose of 500, if you gave them 10 units of insulin, IV push, it didn't do much. 6 minutes later, you've only got 5 units of insulin working. 6 minutes after that, you've only got 2.5, and it just, so within half an hour, there's no insulin left. And we kept giving more and more insulin, and it didn't make any difference. We found out that the thing to do is to give a drip, slow drip of insulin over, give that 10 units over a whole hour, and you get more bang for your buck. This little slide here shows the effect of what happens at fat or muscle tissue. This is this particular line here is what happens to the extracellular glucose, and this is the intracellular glucose. So no matter how much you increase the extracellular glucose without insulin, all the way up into the 600-800 range here, you don't get any increase of intracellular glucose. Where there's a straight line, the more, in the presence of insulin, the more glucose extracellularly, the more glucose intracellularly. That's just, yeah. So, basic problem in diabetes, that carbohydrate utilization is reduced. The utilization of lipids and proteins is enhanced. Insulin increases membrane permeability, increases glucose phosphorylation, which is what gets all that ATP, which is the energy for your cells, increases glycogenesis, production of glycogen in the liver for storage, increases fat synthesis, making more fats, taking excess glucose and putting it into fat stores, and it suppresses, it's a suppressor, it suppresses glucagon and epinephrine release. Now, when your blood glucose levels fall, and this is in the normal person who has adequate insulin, glucagon is released. Glucagon makes the liver break up the glycogen to produce glucose. Epinephrine and norepinephrine are released from the adrenal medulla. Fat metabolism is enhanced, producing and also makes glycogen, which then becomes broken down into glucose through glycogenolysis. Cortisol is increased from the adrenal cortex, which increases fat metabolism. Growth hormone is released from the pituitary, which enhances metabolic activity in general throughout the body. Insulin production and release is inhibited when your glucose falls. So it's a feedback mechanism both ways. Now, type 1 diabetes, body stops producing insulin or produces too little insulin to regulate blood glucose level. And this is mostly genetically determined. Type 2 diabetes still has the pancreas secreting insulin, but there's insulin resistance, possibly because the insulin is not being made appropriately at the moment, or the cells don't it doesn't work with the carrier protein as well as it should, but you're still secreting insulin. Maybe not enough, and it's usually acting incorrectly. Type 1 diabetes with decreased insulin production, that's 10% of all diabetic patients, about 15 persons out of 100,000. Early onset, so probably never later than adolescence, early adolescence. The average is, somewhere around 9 to 10. Genetically more likely to develop in Caucasians, at least in the United States, than in blacks or Hispanics in the United States. If it happens after age 20, it's not type 1 diabetes. It's not what we would call juvenile diabetes. All type 1 diabetics are insulin dependent. You cannot treat them with pills alone. They will require exogenous insulin. And type 1 diabetics have increased risk of infections involving kidney disease, ocular disease, go blind early from small vessel disease, nerve injury, peripheral neuropathies, hypertension, coronary artery disease, cardiovascular accidents, strokes. This is small vessel disease. Small vessels go bad with type 1 diabetics, with any diabetic actually. Now, so insulin dependent diabetes mellitus, IDDM. The beta cells are either destroyed or they're not producing adequate insulin. There's also an increase in glucagon production goes along with it from the alpha cell as whether this is a genetically determined thing or not. Remember, peak onset 11 or 10 to 11. New onset over 30 is probably not true. It just doesn't happen. I don't think I've ever seen I've seen people who are insulin dependent as type 2 diabetics, but not who developed type 1 diabetes when they were in their 20s and 30s. That just doesn't happen. You can still be insulin dependent and be a type 2 diabetic. Now, we don't know whether this is possibly viral mediated, whether it's environmental or genetic. More cases occur in the fall and in the spring when there's higher levels of viruses around. Maybe it's a genetic predisposition, and then by catching a certain virus may push that genetic predisposition into actually occurring. Symptom onset is often abrupt, and they're very prone to ketoacidosis. And to this day, about 40% of previously undiagnosed juvenile diabetics are first diagnosed when they become ketoacidotic. They'll show up in ketoacidosis as the first thing we're aware of. And that's even with mom. The problem is, how do you know if a kid is, all kids eat a lot sometimes. You don't know whether they're drinking a lot, whether they're peeing a lot. If they're 11 years old, they're not telling their mom that hey, boy, I'm really going to the bathroom a lot. It doesn't happen. So you don't see that's going on, and a lot of active kids look real skinny. They start getting skinnier because they start stealing proteins to produce glucose. Now, your clinical presentation. Classic diabetes mellitus, type 1. Polydipsia. Okay, increased blood glucose. So you've got increased glucose levels in the blood, 200, 250, 300, and it's sucks water out of the cells intracellularly. So that triggers thirst response. Because you've got increased blood glucose, you start getting an osmotic diuresis because the kidney starts leaking, starts losing glucose at about 180. So normally you don't have any sugar in your urine because your blood glucose is under 180. You're not filtering it, but you start filtering glucose through the kidney when it goes above 180. So you get into the 200 and 250. You've got a lot of sugar going out in the urine, and that sucks water along with it, just osmotically. So you end up urinating out a lot of sweet urine. Polyphagia. You want to eat a lot. Decreased cellular carbohydrate, fats, and proteins are begin to get stolen from the body to produce glucose. So the cells are basically starving, and that triggers the pituitary to make you want to eat more. Gastrin is produced, which makes you want to eat more too. Weight loss due to the loss of fluid and tissue mass from protein. Fatigue, because you don't produce all that lovely ATP through normal oxidative phosphorylation. You're now working on the Krebs cycle and glucolysis alone, which ends up with only for every gram of glucose you take in, or every gram of fat you have and protein, you only end up with about 4 units of ATP instead of the 38 you should have. And people are just fatigued. They don't have enough energy. Okay. Now, type 2 diabetes. Insulin resistant. For some reason, the insulin doesn't work well at your tissue level. 90% of all diabetics are type 2. That's 6.2% of the population in 2002. It's probably a little bit higher than that now. It's probably closer to 7 or 8%. It is related to obesity. Affects all ages, becoming more common among adolescents. So they're, you say, well, is this a juvenile onset diabetic, or is this a diabetic who is simply a type 2 because he's a fat little 13-year-old? more present among more prevalent among Hispanics, Native Americans, African Americans, and Asians. Now, what does type 2 diabetes get you if you have type 2 instead of juvenile? It gets you exactly the same problems if you don't manage it. Increased risk of infections, increased risk of kidney disease. And kidney disease we'll talk about later on, I think, because kidney disease, diabetes is the most common cause of kidney failure in the United States. And it's memorialized because it's in Medicare language for years and years and years for dialysis and now for kidney transplant. So it's a well-paying problem that keep the kidney surgeons going. Ocular disease, nerve injury, peripheral neuropathies, hypertension, cardiovascular disease, cerebral vascular disease. Most type 2 diabetics could be controlled with diet, a diabetic diet where you force your body to use proteins and fats and glucose to its maximum. Exercise. Exercise produces increased cortisol, increased amounts of epinephrine, which affects your carbohydrate, improves carbohydrate management, and weight loss. So type 2 diabetics are not without some way of helping themselves, except that most people prefer to take pills. So oral medications generally work on most type 2 diabetics, except when they're really bad, and then they will require insulin along with it. Now, they may have normal insulin levels. The beta cells may look normal under a pathologic examination, but for some reason they have a poor utilization of the insulin that they are making. Generally occurs over age 40, most cases. Patients usually obese, has end organ complications by the time they really get aggressively managed. More common in adults with lower socioeconomic and education status in this country. Increased incidence in women with women who have had lots of children. The pathology occurring with type 2 diabetics is chronic and acute dehydration. Just like that basically is the basic problem, a basic problem with type 1 diabetics. The cells are dehydrated because a high osmotic load outside the cell pulls cells out. They have an osmotic diuresis because they're passing sugar out through the urine, which is sucking water out with them. Acidosis, increase in keto acids because they've gone to fats. Hyponatremia because sodium follows those keto acids when they're excreted by the kidney. Potassium is depleted because potassium goes out of the cell following sugar. Then it follows sugar out through the urine, through the kidney. Basic rule is potassium follows sugar. If you want to change someone's potassium level, you you either take the sugars out of the system, which pulls the potassium with it, or put sugars back into the cells, which takes potassium into the cell where it belongs. End organ complication of all diabetics, accelerated atherosclerosis with what's called medial calcification, so the media, the media, the middle section of the small artery becomes calcified. So you get atherosclerosis, narrowing the lumen, and the media also becomes calcified, so it can't contract and expand. Microvascular disease, particularly at the level of what's called the capillary basement membrane, and that's important in the kidney. That's why kidneys go bad, is because they're at the microvascular portion of the kidney where the filtration occurs. These small vessels degenerate, so they don't exist anymore. Kidney function is materially affected then. There's demyelination of nerves, so peripheral neuropathy occurs. There's also autonomic dysfunction, so the nerves of the autonomic system of your gut, etc., are demyelinated so that they don't function normally. And also the Schwann cells, which are important in peripheral nerves, degenerate. Okay, a couple of emergencies in diabetes. Hypoglycemia. Fall in blood glucose concentration that elicits symptoms of glucose deprivation in the central nervous system. Remember, I said that of the two organ systems that don't require, they don't have a transport mechanism, the brain and the red cell. Well, the red cell doesn't give you any symptoms if it gets a little low on glucose, but the brain does. And if you get a sudden drop of glucose, because the brain then is depending simply on an adequate level of glucose circulating to get into the cell. The more glucose, the more sugar goes into brain cells. Least amount of glucose, least amount of sugar goes in. It's about a 60% transmit. So if you have a glucose of 100, you have about an intracellular brain glucose of 60, the equivalent of that. If you have a glucose of 50, you have an intracellular brain glucose of 30. If you have a glucose of 30, you have an intracellular glucose of 18. Not very good. That's not enough to get. Your brain likes to be running at about 60, 50 to 60, the level, 50 to 60. So there's not enough below that. Suddenly, if you get a sudden drop in glucose, you get adrenergic because you get epinephrine release. That's why diabetics have a problem knowing if they're becoming hypoglycemic when they're on beta blockers, because they don't get the adrenergic effect from the, because the beta blocker stops it. They can't get increased tachycardia. They can't get diaphoresis. They don't get sweaty, pallor, tremulousness. They don't get a tachycardia or palpitations, and so they can go into hypoglycemia very easily because they don't recognize the symptoms. Most of us, when our glucose falls, you get hungry. You want to eat, or you feel crabby and jumpy and stuff, and you say, God, I got to eat something. That doesn't mean you're a diabetic. That means that you just are having normal adrenergic symptomatology. Visual disturbances, spots, mental confusion, weakness, things that sudden drop in glucose. Your brain is not getting enough sugar. Now, gradually, if you have hypoglycemia over a slower period of time, fatigue, confusion, headache, memory loss, and then suddenly, if you drop low enough and you have not only mental confusion, but of course you can have seizures from it. We used to treat We used to treat schizophrenic by giving them inducing a hypoglycemic seizure. That taught them not to, that didn't cure them, that what that did was, it was behavioral. It taught them not to do whatever it was that was pissing you off so that you wouldn't do it again. Now, you can have hypoglycemia spontaneously from problems in the GI tract, mostly defects in the gut, sometimes after GI surgery, sometimes after transposing, doing an intestinal bypass. They have a for obesity, they have a tendency to go a little hypoglycemic on you. Early diabetes, new onset type 2, because you're getting varied levels of insulin resistance. And so because the insulin isn't working right, your pancreas produces more insulin suddenly, and you can get hypoglycemic from that, because then it does work at some level. So often if people have, and they're in their 30s, 40s, 50s, and they're having symptoms that are similar to hypoglycemia, we'll test them out, give them a glucose challenge, and normally see how your glucose goes up. What happens is their glucose will rise very rapidly, and they will become hyperglycemic, and then suddenly it'll fall, and that'll reproduce the symptoms that they have. We give them a measured amounts of glucose. So it's not uncommon to get hypoglycemia as the first symptom that you may be going into type 2 diabetes. You can have tumors of the kidney, of the pancreas, islet cell tumors, which produce insulin. You can have neoplasms outside the pancreas that stimulate the pancreas to produce more insulin and become hypoglycemic. This is pretty unusual. Induced hypoglycemia is usually insulin, type 1 diabetics or type 2 diabetics who have to take some insulin and just taking too much, and they're not covering it with enough sugar. So most induced hypoglycemia is insulin, too much insulin. The oral hypoglycemic agents, particularly the sulfonylureas, produce hypoglycemia, and when they do, that means there's something wrong with the dosing at that level. Their body has changed, something has changed, so that because if they get hypoglycemic from an oral agent, there's something materially wrong with how their body is managing that drug at that moment. So you end up, if you have, the caveat I give you is that if you have often if you have a known insulin-dependent diabetic and they get hypoglycemia, you give them sugar, they wake up, you retest it, they're now adequate, they're eating, they're talking to you, they don't have to come to the hospital. They don't have to get worked up because they'll be okay. This happened. They just may need to readjust their insulin. Usually it's a mistake. They took their insulin and they didn't eat for that morning for whatever reason. If they're on a oral diabetic agent, they're going to go hypoglycemic again, probably within that first 12 to 24 hours. They need to go in and get evaluated and get readjusted because there's something wrong. Alcohol, now it may be simple as that. Alcohol will produce hypoglycemia by itself. It's basically your body's getting cheap sugar and producing a lot of insulin to try to cover that, and it drops your glucose. Certain drugs, high levels of aspirin will cause hypoglycemia, almost in the fact that it sort of displaces the glucose. Now, so In a diabetic emergency or a suspected diabetic emergency, usually you're going to get called because there's altered mental status. Maybe they've had a seizure. You get there, they have altered mental status. ABCs, history from patients and family bystanders. Be sure to, make sure when you say, do they have any problem? If they've had a seizure and they say, yeah, they're epileptic, make sure or make sure that they didn't say, yeah, they're diabetic, or that they're really diabetic instead of epileptic, because that can be confusing sometimes. If their glucose is less than 60, patient's conscious, give them oral glucose, something. If they're unable to take it orally, IV and 25 grams of D50, that's assuming we have D50. It seems to be running short these days. Otherwise, you have to give them D25 if you have that. Child gets 0.5 grams per kilo. If you can't start an IV or orals, glucagon, sub-Q or IM, milligram. Repeat the glucoscan after the glucose administration. Transport all patients who are on an oral antihypoglycemic. In general, give D50 for any hypoglycemia under 50, even if you gave the oral glucose. Even if they're able to take orals, get some in there. Check it. If it's insulin dependent only, and their glucose is adequate, and they're eating something, you can leave them at home. Want to take a break? Okay. We'll take a break for 10 minutes. More diabetic things. Ketoacidosis, another true diabetic emergency. So, ketoacidosis is an absolute or relative deficiency of insulin. So it could be type 1, could be type 2. So it's either an absolute or relative deficiency of insulin with an increase in the insulin counter-regulatory hormones. So increase in epinephrine, increase in cortisol, increase in glucagon, increase in growth hormone. Hepatic glucose production from glycogen increases, so blood glucose goes up more. Fat mobilization increases to take glycerol, produce more glycogen from that to produce more glucose. Peripheral glucose utilization decreases because of the absence or relative deficiency of the insulin. And ketogenesis is stimulated because you start going to fat metabolism. Now, this is a very busy little slide. But the important things here is what it ends up right here, which is called shock and central nervous system depression. So, starts out, decrease insulin. So you've got decreased insulin use, increased levels of hormones associated with stress, catecholamines, increased glucose production, increased glucagon, decreased insulin use, increased blood glucose levels, solute diuresis, sugar in the urine, polyuria, increased blood glucose, hyperosmolality, causes polydipsia, you're after more water, polyuria, dehydration, increased thirst, hypovolemia, and shock. Down this line, decreased insulin, increased release of fatty acids, increased ketones, accumulation of beta-hydroxybutyrate and acetoacetic acid, metabolic acidosis, ketones in the urine. You don't test for that, but we test for it. You don't. Metabolic acidosis produces Kussmaul breathing. Why? Trying to blow off carbon dioxide, decrease the acidosis, and central nervous depression, and so you've got CNS depression and shock. The bottom line of this is you're mostly dealing with shock. Yeah. Yeah, well, it's on the test, isn't it? So the bottom line is dehydration and shock, and then at the same time ketone production from utilizing fats instead of glucose for energy. Fats produce X amount of, when they break down, they produce X amount of ATP. However, they produce ketones, ketone bodies as a side effect, because those are incompletely metabolized. Clinical manifestations of ketoacidosis: polyuria, dehydration, sodium, phosphorus, and magnesium deficits. Remember, your sodium is wasted, but you also have profound hypokalemia, cellular hypokalemia, even though often we test their because the potassium has come out of the cell into the blood. It's gone out of the blood through the kidney, urinated out. So you lost total body stores of potassium, but a lot of times we'll test the potassium when they first come in, and because they've got so much glucose, they've got a lot of potassium in it too, so it'll appear normal. So you always get nervous if you, I always got nervous if you had a patient who had blood glucose, ketoacidosis, blood glucose of 500 and a potassium of 4.5, which is normal, because you know that that's not what the inside of his cells look like. And so we correct everything else, but forget to give them some potassium, and then they're really potassium depleted, and they'll end up with profound symptoms of hypokalemia. Kussmaul respirations, postural dizziness, shock, CNS depression, shock, and too many ketones, ketonuria, anorexia. People who are ketotic aren't hungry at that point. Nausea, they're also sick to their stomach. Abdominal pain, a lot of times it's almost like they have pancreatitis. They'll have that kind of abdominal pain. Thirst, polyuria. Treatment, do your ultramentation protocol, and fluid, and fluid, and fluid. So, how much fluid? Well, at a minimum for an adult, 1,000 to 2,000 cc's by the time you get them to the ED, depending on how far you have to transport them. Now, because they're in shock, they're unlikely to go into, even if they're old people with cardiac disease, they're shocking enough, they're not likely to, they're so dehydrated, they're not likely to go into anything, into congestive failure on you. So just give them fluids. A child, 20 cc's per kilo fluid challenge, repeat it. Repeat it up to 3 times if you get them in there. Most kids we can get their glucose down from high 500 or so down into the 300, and it's with just a liter or 2 of fluid. Okay, alcoholic ketoacidosis. This occurs when there's acute cessation of alcohol consumption after chronic abuse. So they may go hypoglycemic on you instead of having a withdrawal. This will happen usually about the same time they might withdraw. Often occurs in binge drinking, associated with lack of appetite, dehydration as well, from the alcohol itself too. Clinical presentation, nausea, vomiting, abdominal pain, and shortness of breath often. They need fluid resuscitation also. and we will treat them ultimately with insulin as well. Now, if you give them glucose, and they sometimes can be hypoglycemic along with ketoacidotic. They're going to ketone production, and they may be relatively normal or low glucose. If we give them glucose, then that stimulates insulin production, which stimulates their body to go back to doing regular glucose processing, producing enough ATP from that phosphorylation process, reducing the ketone bodies by itself. Now, hyperosmolar hyperglycemic non-ketotic syndrome, HHNS. Common type 2 diabetics, no ketosis. They don't produce ketone. They don't use fat metabolism. They just keep getting more, because remember, their insulin is still there. It's not working as well as it should have. There's insulin resistance, but they still have insulin production to go to that phosphorylation curve, so they don't turn to fats, so they don't produce ketone. But what they do is produce higher and higher and higher levels of glucose. Ordinarily, we say somewhere between 1,000 to 1,200 is a glucose. It's not uncommon, 800 to 1,000. I think we had a record a year ago. We had one at 2,200. Now, we actually used the serum to make jam. You know, it was so. The serum glucose is often very high compared to diabetic ketoacidosis, and you don't have the ability. You know, we don't give you the ability to test for ketones in the field, but you know, this is suspected if you have a really high glucose. Now, your glucose meters will stop at about 500, don't they? They say high. Yeah. So. And so do ours, but you know how we tell how high these are. We dilute the serum sample today, and you don't have time to do that in the field. But if it's way over, if it's turns high just like that, and you get and you suspect that this is maybe, because they don't smell like ketones. Happily, half of your diabetics, when they're in ketoacidosis, you can smell the ketones very easily. Acetone kind of smell. Overripe banana kind of smell. You can suspect this. Otherwise, we do it by diluting, doing serial dilutions of the glucose of the serum to see, dilute it by half, and you find, if it's still above 500, then we dilute it again, and test it out that way. These people will have a lot of glucosuria, a lot of urination because of the huge osmotic load, neurologic changes, mostly confusion, to coma. They need, once again, fluid. Their basic problem with these is they're dehydrated, cellularly dehydrated, so they need lots of fluid. They'll also need electrolyte replacement. And they have extremely high mortality, probably because the ketoacidotic comes to your attention when they have a glucose only in the 500 range, 400 to 500. They develop ketoacid, and they have the symptoms of ketoacidosis, confusion and shock. These don't develop it until they're really, really super high glucose, super high internal dehydration. They're usually a little bit older, so they have a higher risk. There's a funny thing that occurs. Mark threw this one in for fun. It's called the Samoji effect. It's called rebound hyperglycemia. what happens when we try to adjust, particularly insulin-dependent diabetics, we sometimes, as you start giving them more and more, you test their glucose and say, well, we need to give them more insulin, and we give them more and more insulin, and their glucose levels keep rising. And it's because the counter-regulatory hormones, the epinephrine, the cortisol, have been stimulated by sudden drops of sugar, and it suppresses the insulin. So the sugar rises even though they have insulin present, because the insulin gets suppressed. And we keep cranking higher, and then suddenly they'll drop the bottom out and become hypoglycemic because they have so much insulin around. It can also be affected by giving someone too much carbs, and because that'll suppress your insulin level. And there's a very confusing slide here that I'm going to forget. The bottom line on this slide is that you start out with lots of insulin, and you can get counter-regulatory things which give you hyperglycemia, which is not to be expected. But that's because your counter-regulatory mechanisms have been stimulated. Okay. Common oral medications for diabetes. Oral agents. This come in the flavors of sulfonylureas, which increase insulin secretion, and they can give you severe hypoglycemia. Now, these are known as these are glipizide, gliburide, glucagon itself, chlorpropamide, talazimide, tolbutamide, glimepiride. These are the sulfonylureas. Now, they often give one or two different oral medications at the same time. There are the alpha-glucosidase inhibitors, which decrease carbohydrate absorption. Those are the ones that end in miglitol. There's a whole bunch of different things, or acarbose. I don't know how they come up with names. There's a whole science of coming up with stupid names. So you could give someone sulfonylureas, which would increase insulin production, and then miglitol, which decreases carbohydrate absorption, and kind of adjusts somebody. That's if they don't want to stick to their diet, basically. The biguanides decrease the hepatic production and absorption of glucose, so they will decrease the gluconeogenesis. And that's metformin or glucophage. And then the thiazolidinones they increase the effect of insulin. They're fairly new drugs, Avandia and Actos. And sometimes you'll get those along with the sulfonylurea. So sometimes people can be on one agent, two agents, three agents even. And there are some side effects of these things, mostly hypoglycemic episodes, but there are long-term side effects. There's been some increase in risk of cardiovascular disease from a couple of these. Your insulins come in rapid, intermediate, and long-acting. And often insulin-dependent diabetics will have some rapid and some long-acting insulin. Uncommon to have the intermediate ones as much anymore. So your rapid-acting is regular, Novulin R, Humulin R, Lispro, and Semilenti. Those are rapid-acting. The onset of action is 15 minutes, and that's if it's injected sub-Q. Now, the onset is almost immediate if regular is injected intravenously. Now, as a drip. Now, we're obviously not going to give any long-acting insulin intravenously. All the intravenous insulin, the insulin drip is a regular, short-acting, short onset, doesn't last very long. Remember, the half-life of regular insulin is only 6 minutes. sub-Q, it lasts a little long because it's slowly absorbed. Intermediate insulin, their onset's about an hour, lasts about 2.5 hours. NPH, humulin N, ovulin N, lente. And then the long-acting 4 to 8 hour insulins is called ultralente. Now, the physician, the diabetologist will work out for that person's glucose curve, work out what would be the, so most of the time, most diabetics take insulin twice a day. They take it before breakfast or at breakfast time, and the regular insulin covers them for their breakfast meal. The long-acting insulin or intermediate that's thrown in there for good luck will cover them basically for lunch. Then they take their next dose of insulin before dinner. Regular for the immediate effect and long-acting or intermediate for the long-term effect. Now, some diabetics are so brittle, we call it diabetic brittle if they're really hard to adjust their glucose with insulin. They'll take insulin before breakfast, before lunch, before dinner, and before bedtime. That's a lot of poking yourself. And they have to do glucose checks. We usually have them adjust their glucose once they get trained to it. They adjust their insulin based on what their glucose levels are. Some people will require them to take a snack before bedtime because otherwise, well, you can guess it. They wake up or they have a seizure in the middle of the night because they become hypoglycemic. They didn't know they were hypoglycemic. They were asleep, and that's because their long-acting insulin either has to be decreased, or you have to have a snack before bedtime to give a little glucose to cover it. So it's kind of now there are some nice things, there's some new things occurring so that they have insulin pumps, which are not without problem. They load them, they have it, they're just always injecting a little insulin sub-Q from this pump, and but they don't have to check their sugars theoretically, even though they still get my experience with those is most people get hypoglycemic anyway. So they have to learn how to adjust that. Okay. So if you get called out on a hypoglycemic, it's around the lunch hour, you know that they either didn't have their breakfast to cover their regular insulin, or they're taking too much insulin, or it has to be adjusted. And this is where history comes in real handy. Now, for you, it doesn't make any difference. You give somebody who's hypoglycemic glucose to make them better. Okay. Last thing, talking about diabetes, we're going to talk about a couple things. Hyperglycemia, or hyperkalemia, rather. Now, there are a lot of other complications of diabetes, but we will focus only on diabetes as the cause of hyperkalemia. The most common cause of hyperkalemia associated with diabetes is renal disease. Then hyperglycemia occurs in the presence of renal disease when you get a cellular shift of potassium. This is because of glucose. Potassium follows that glucose. So it's going to follow the glucose out of the cell into the hyperglycemic serum. It's going to then ultimately follow the glucose out of the urine from the kidney. However, if you have kidney disease, you can't excrete the glucose, and you can't excrete the potassium either. So you end up just with increasing serum levels of potassium. Now, your clinical presentation of hyperkalemia, and we've picked up a lot of hyperkalemia in the last couple of years, but we've missed a couple too, because we've looked only for tall peak T waves. Now, it's relatively easy to think hyperkalemia when you get someone who's known to have kidney disease, and you know they have kidney disease because they say, I'm on dialysis, or I should have had dialysis this morning, and now I have symptoms of weakness and confusion and funny heartbeats and stuff, and you look and you say, well, this guy's probably hyperkalemic, and I look at the thing and see, oh, T waves, big peak T waves, yeah, that's hyperkalemia. However, the progression of hyperkalemia, your normal potassium's about 4.5. So normal is about 3.5 to 5 serum potassium. With potassium rising to about 6, you get peaked, and they're called tented, peaked T waves. They look different than a normal T wave. I mean, they may not be as tall, but they're peaked. Get peak T waves, and then as you begin progressing up the curve from between 6 to 7, the P wave starts to flatten out. The P wave first looks pretty normal. Then it starts to flatten out. It doesn't all the way go away at that 6 to 7 level, but it gets flat. You still have the tented peaked T waves. The PR interval, you basically go, it increases. You basically go into a first-degree block. At a level of about 6, the QRS begins to widen, and it doesn't look quite as normal as it begins to approximate looking like a left bundle branch block or a right bundle branch block, a widened QRS. The T wave further flattens. It may even disappear. Between 8 and 9, the QRS complex the S wave begins to drop, gets bigger and deeper, so that QRS, instead of looking like a normal QRS, begins to start looking like a biphasic or almost sinusoidal QRS. The T wave is probably gone. The S and the T run together. Now your T wave is not as peaked, is not as obvious, because the S wave has run into it. So it's looking more like the T wave is getting harder to find. It's not peaked. So you say, well, I'm looking at T wave, but I've got this wider complex. Between 9 and 10, that becomes a sine wave pattern. No T wave. You've got this sine wave. You may not get a pulse with that. You go into cardiac arrest after that shortly, so VFib. So you're not going to find peak T waves all the way to the end. The worst thing is the sinusoidal pattern that doesn't look right. You go to either complete heart block, VFib, or asystole. So here's your peaked T waves. Now these are nice. These are nice because, at least in V4, they are bigger than the QRS complexes, but that's okay. The other thing that you can see in this, which we don't talk a lot, this is an abnormal R wave progression. You should have decent R waves. You should have R waves starting here, but you don't really see a good R wave until you get out here, which is it's just an abnormal progression. But you wouldn't diagnose hyperkalemia on that. That's just a bonus. But these are peak T waves. Now, sometimes good clinicians won't pick this up because they haven't asked the patient the right questions. You've got to suspect it when you have somebody who's got paresthesias as well. They may have decreased reflexes. They may be relatively may have weakness of the upper extremities more than their lower extremities. It's dysfunctional, and nausea, vomiting, and diarrhea, so they could have lost potassium through that process, or lost sodium rather, and retained potassium with the diarrhea. So, but it's mostly going to be history. If you have somebody who has a recent crush injury, who has potential for having acute renal failure. So all those things you can throw in for good luck. Yeah. Hyperkalemia, relatively easy to treat. 3 phases. Cardiac membrane stabilization, shift potassium intracellularly. Remember, potassium follows that glucose. And potassium excretion. So, you do membrane stabilization first. Calcium chloride, 5 cc slow IV. Now, always remember, calcium, when you do calcium in any patient, you give it slow. Calcium fast can have really deleterious effect on the heart. Like, what's called a stone heart. It goes into vicious tetanic contraction and then doesn't relax again. That's a bad thing. So you give potassium slowly. How slow is slow? Well, you guys are in an emergent situation. You're going to give it over 2 to 5 minutes if you can. 2 minutes is fine, probably fine. At the same time, you can be giving them albuterol by a med-neb. Albuterol shifts potassium into the cell. It's an odd thing. We found that out long ago when bringing all the asthmatics in, and they all had relatively low potassium. They were low by about 0.5. That's exactly what happens to normal people. You give any normal person or any diabetic or anyone who's got hyperkalemia, give them albuterol med-neb, and it shifts potassium into the cells to the tune of 0.5, 0.5. So if they were at a level of 6.5, they come to a level of 6 automatically. In Europe, they use intravenous albuterol. 10 milligrams of albuterol intravenously. That hasn't been cleared by the FDA. Sodium bicarbonate. Now that's another membrane stabilizer at this point. And it shifts potassium to the cell by producing alkalosis of the serum, relative alkalosis, briefly, which shifts potassium into the cell. Then, if the patient is diabetic, and remember, most of the people who have chronic renal disease are diabetic. A large number of them will have insulin. If they have insulin available, regular insulin, Humulin R, Novulin R, anything that says R on it, you can give them D50, 25 grams of D50, and chase it with 5 units of that person's insulin. That will shift potassium into the cell because the glucose will go into the cell with the insulin and the potassium follows it. The potassium belongs inside the cell, not outside the cell. Even if they have renal disease, they get some reaction to furosemide, to Lasix, so they will excrete some potassium with Lasix. Almost all chronic renal failures who have dialysis will also get some. They do have some urine production. It's not very efficient urine production, which it doesn't remove all this stuff, but they will remove some potassium that way. Renal failure is one of the complications. It's one of the worst complications of diabetes, and it's based on basically small vessel disease. You get hyperglycemia, hyperfiltration, and Mark says insert basic science here. what happens with that hyperfiltration is that dehydrates the microcapillary, which is your filtering unit, dehydrates the glomerular unit, which causes increased in basement membrane disruption of the glomerulus, which increases your deposition of calcium and atherosclerosis, and the glomerulus is ultimately dead. So it doesn't have the filtration anymore. Then they can't filter glucose as well anymore either. They can't filter out any of the solutes as well as the glucose. So with the damage to this microfiltration structure, all of your sodium excretion is affected, your potassium excretion is affected, and we're not moving ahead. There we go. And the normal kidney functions, maintaining proper blood volume with the normal balance of water, electrolytes, and pH. Your kidney is the long-term adjuster of your pH, of your acid-base thing. Short-term is respiratory system and the buffer system of the body. Long-term is the kidney. Kidney has to excrete acids, retain bicarbonates, to buffer the blood. When it can't filter, when the glomerulus is ruined, it cannot filter these things. Can't filter excess of glucose, can't filter excess sodium, can't filter excess potassium. So all these things increase water, sodium, potassium, increase retention of glucose, and increase ureas. Urea is excreted by the kidney. Can't do it, the glomerulus is ruined. Because of it disrupts the renin and angiotensin loop, patients get hypertension. Hypertension further damages the glomerulus. Red cell development, normal blood production depends on the production of erythropoietin from the kidney. If erythropoietin is not produced, so you get chronic anemia. So people with chronic renal failure have anemia, hypertension, increase in retention of sodium, water. They have too much total body water, too much electrolytes, too much glucose. That's why the only thing that saves them is you put them on, you either give them a kidney transplant or you put them on dialysis. Not everybody can get a kidney, so you go on dialysis. And under Medicare rules, the minute you go qualify for dialysis, you now qualify for the renal transplant program. But it's a time to get kidneys. A lot of people don't like to give up a kidney. So, in assessing chronic renal failure, you have to differentiate between chronic problems and acute problems, which you do entirely by history and physical exam. Acute GI complaints, probably acute problem. Changes in mental status, acute problem. Marked abnormalities during your physical exam, acute problem. Uremic frost, that's you get there, the patient is somewhat puffy looking because they're retaining fluid. They're retaining electrolytes. Because they can't excrete urea, urea is excreted through sweat glands and through, particularly around the face, and you can get what's called the uremic frost, a little white coating around the lips, which is actual urea excreted. Chronic renal failure, a lot of headaches. They can't concentrate their urine, so they have polyuria, and then ultimately will have oliguria. The worst thing with a chronic renal failure is you stop producing any urine at all. Their BUN, the blood urea nitrogen, and the creatinine go up. They get chronic edema. Their filtration rate kidney drops, although it is present, so they do respond to Lasix. Anemia, hypertension, weakness, and fatigue. All right. Happily. Now we get, what is this? Okay, we have some case reviews. Okay. Okay, did we answer all the questions that are on the little quizzy? Okay. Well, happily, we have actually some case reviews. We have a few case reviews here that actually are germane to the subject today. Code 3 on a diabetic problem. 50-year-old male sitting on the edge of the bed, awake, able to answer questions appropriately. Gross exam reveals patient with poor health, ascites, distension in the abdomen, skin pale. Patient's mother, remember, this is a 50-year-old. Patient's mother called 911 after hearing a thud in the patient's bedroom and was unable to get the patient back into bed. Denies neck, back, or head pain, GCS of 15, doesn't remember if he fell, thought maybe he had a syncopal episode, didn't know for sure. Blood glucose is 548. Reports blood sugars have been reading high for 1 week. Moved to Gurney, to the MICU. Weak, thready radial pulse. Strong brachial with blood pressure of 80. Unable to obtain IV access. Transported with no change in patient condition. So GCS was 15. Blood pressure 80. Thready pulses. Pulse ox 98. Continued to stay at GCS of 15. Couldn't get vascular abscess. Blood pressure stayed at 82. Transported. I don't think no one really wanted to put a drill in this guy. So in hospital, glucose more than 500. Gave him fluids. Started him on an insulin drip. We generally don't start the insulin drip until we've got about 1 liter or 2 of fluids in. Although with this guy, we might argue that because he's so alert, this might be early hyperosmotic, hyperglycemic. So he also was hyperkalemic. Unfortunately, we don't have the 12 lead with that. He had a hyperkalemia of 6.7. He was treated with insulin, and he didn't have to have enough. He didn't have to have any more glucose, right? He's got glucose of 500, so that's more than enough. How much in a normal person, if you give them 25 grams of glucose, how much do you raise their blood glucose? Usually about 60 to 80. Yeah, sometimes you'll get it all the way up to 200 from 60, but usually it goes up into the 120 to 150 range. So he had plenty of glucose, so they just gave him the insulin, which chased the potassium inboard, gave him some Lasix, got him to lose some of the potassium that way, and they hydrated him, which makes the trick as well. And they treat him with K-Exolate, which is it just binds to potassium. It's usually given by rectal enema. We don't, which is why we don't carry it in the field. Thank you. Right. Yeah, I'll take your thanks at any time. Yeah. Patient also had low sodium. He was hypotensive, of course. He had a history of cirrhosis, which also gives him low sodium. And he was discharged home with stabilized blood glucose. And then we ran at him with an out-of-hospital cardiac arrest 2 days later. At that time, his Pre-hospital blood glucose was 30. It was asystolic. Transported, ultimately died in the ED. Case 2. Called 911 when he found his wife in bed, pulseless and apneic. Husband was instructed to perform CPR. The call taker started on CPR, but he was only able to get the patient out of bed and onto the floor by the time EMS arrived. Patient has had fluctuating blood sugars lately. Last night he gave her some candy for at bedtime. Okay. Couldn't get a systolic blood pressure initially, pulseless, assisted ventilations, did CPR. Let's see, how old is she? 50-ish? Yeah, she's also around 50. Continued, she had an asystolic, apparently asystolic, initially found, started on fluid. Blood glucose was 474. Got some naloxone, unchanged. Continued chest compression. She got some epinephrine. I believe she also got a amp of bicarbonate in here. Was intubated. She had a good waveform, ETCO2. First level of ETCO2 I noticed down there was somewhere in the neighborhood, somewhere in the 30s or 40s. Well, this goes on and on. More epinephrine, got some sodium bicarbonate. She's developed. She got pulses at one point, pulse at the carotid, and waveform. Her capnography shows 16. Then within a few minutes, it's 65. She gets a return of circulation at some points, then loses circulation again, and every time she gets pulses back, she gets a bump in her CO2. No. Yeah. At any rate, she ultimately has return of spontaneous circulation and is taken to the hospital, transported. As DKA in coma, blood glucose was 500 plus. She had acute sinusitis and mastoiditis. This is what tips type 1 and type 2 diabetics into ketoacidosis. Often is a intercurrent or a concurrent infection which raises their metabolic demand, which then raises their blood glucose level to try to feed that metabolic demand, but it's because of the poor insulin function, it's not getting into the cells, so you raise the blood glucose and they ultimately dehydrate and go into fatty acid utilization and go into diabetic ketoacidosis because of a cold, because of, in this case, sinusitis and mastoiditis. She also had aspiration pneumonia, probably gotten at the time she went down with her cardiac arrest. She was treated with insulin drip, fluids. Because of her cardiac arrest, she was still comatose. She went on to the hypothermia protocol for 2 days. She later developed another PEA arrest. She was resuscitated from that, but she did have ultimately severe anoxic encephalopathy when they pulled the plug, as it were, when they took her off the ventilator. She died of brainstem herniation from severe anoxic encephalopathy. So she died 4 days after this event. But this is, an Had she not had the infection, had she not gone into keto, as she recognized how sick she was, had she gone into, has she gotten treated for her infection and for her developing ketoacidosis, she would have, and I don't think she'd ever had ketoacidosis before, so she didn't really understand, or no one in the family understood this, she would not have gone into a cardiac arrest due to the ketoacidosis. Okay, 23-year-old male. This is I've already discussed this with the medic. We have a slight error. I want you guys to be careful out there. Patient states who are doing the laundry with acute onset of chest pain, history of previous SVT. Remember, this is a 23-year-old guy. He had SVT 3 years ago, resolved with adenosine. He's sitting on the couch, alert, oriented, anxious, pale, cool, diaphoretic, clutching at chest, regular pulse, rapid, appears in distress. Okay. GCS is good. His heart rate is blood pressure 152 over 118. His pulse is 234. I think we can bet on this as being SVT. So he gets he has occasional PVC. He's diaphoretic, so diaphoretic they had to use Coban to hold the electrodes on him. He couldn't get 12 leads on him because it wasn't dry enough. Couldn't get him dry enough. We got a 4-lead interpreting the EKG. He got some adenosine at 6, and he got adenosine at 12 with improvement. Heart rate dropped to 114. He felt quite a bit better. So there's his simple SVT and his conversion. EKG remains sinus tach at about 114. Then he got, because he continued to complain of chest pain, and they picked up and they gave him 25 milligrams of ketamine instead of 25 micrograms of fentanyl. Well, what's the normal dose of ketamine? 2 mg per kg. So this guy, unless this guy is a 12.5 kilo person, he got a really teeny weeny dose of ketamine, right? And he became happy as a clam. He had, he said, describe his hallucinations. He began humming and singing and laughing, and then it stopped. Then he says, "Boy, I want some more of whatever you gave me. I don't have any chest pain." No, I don't want you to give them ketamine for their chest pain. I mean, it may turn out this guy was basically anxious, but this was simply a med error. They picked up, and I don't know why. They don't, I mean, paramedic admits, he said, this is totally a brain fart because they don't look the same. They don't look the same, but at least when you're dosing at that thing, that's a teeny weeny dose. You're not going to hurt anybody with ketamine, but you're going to hurt yourself because you have to come talk to me about it. So this is amusing in retrospect, but and I don't think anyone would give us any trouble for being happy. So this is not the way to go. Now the next time is he will ask you for that the next day. Now, why I thought, do we need to treat this anxious man with fentanyl for his chest pain after giving adenosine? Because that's not uncommon. They complain of chest pain after getting adenosine because adenosine may be the mediator of that painful experience of angina anyway. Yes, he had a lot before the adenosine. So, it's not like, at that point I would have done a 12 lead before, But just be careful when you pick up the thing, because you put the adenosine, because of the abuse potential, the adenosine is kept in the same packet that your control drugs are. It's not, strictly speaking, a control drug. We don't have to go to the DEA and get it. Okay. Patient, supine at the base of a rock wall. Staff of facility performing chest compressions and rescue breathing. Witness states patient was complaining of chest pain this AM and also reported chest pain last night as well. So he went to the climbing gym, which everyone should do when they have chest pain. And he said, I felt lightheaded when he was climbing halfway up. Then he slumped over, still in the harness. They let him down. He was pulsic, apneic. Immediately began CPR. They had an AED at the facility. Shocked the patient once before arrival. Upon EMS arrival, CPR was continued. First rhythm shows V-fib. What was his rhythm that the AED shocked him at? Okay. Patient shocked twice, and after the second shock, shocked twice by us, and after the second shock, patient had ROSC. They went back into the V-fib rhythm, was shocked a total of 3 times by EMS, once by the AED. After the third EMS shock, patient had ROSC, maintained normal sinus rhythm throughout transport to the hospital. Given Versed due to bucking the tube. So this has all those things. He did get a dose of epinephrine. He got 3 shocks by us, et cetera, et cetera. Do you see anything important in this? Well, that's okay. And then it says 200 joules for the third shock, but you know the machine by that time should be giving what it needs anyway. What's not in this picture? Rock, Alps. Now, goes on, you're not going to find it here either. And you're not going to find it there. In hospital, the guy had an occluded left circumflex. Stent was placed. He received cooling. He had mild short-term memory loss, but discharged on the 4th day. So this is a good save. It's a bad Alps case because we missed it. Because everybody on scene, this is one of the things, you get too many paramedics in the same place and they start questioning, says, are you supposed to give, if they gave a shot, can we give Alps if we do this? Yes, but they didn't. So here's our inclusion criteria again. Non-traumatic out-of-hospital cardiac arrest with vascular access and persistent or recurrent V-fib VTAC after 1 or more shocks. That's what recurrent means, 1 or more shock. No open-labeled amio, no. By the way, they did give him amio. Known hypersensitivity, protected population, the usual suspects, prisoners, minors, pregnancy, traumas, etc., with a no study. What counts as a shock? ROC, EMS-administered shock. You guys. First responder or BLS, AED delivered shock. ALS delivered a shock. Any non-ROC agency shocks that are delivered by an AED. Any AED shock is the first shock. The machine will not give a shock unless it's in V-fib. It just can't do it. So you know automatically. That's why when the hospital says, oh, did you bring in the AED strip? No. The answer is no. You don't have the ability to download that from the AED. You're not going to bring the AED in from the agency to have it interrogated, you know, under the lights. You know, would you do it? But if they gave a shock, it was a shock. It was in V-fib. That's the way it is. If it didn't give a shock, it means it wasn't in V-fib. That's what might be interesting for the hospital to know. But if it gave a shock, who cares? It's V-fib. So we don't count ICD shocks because you have no way of documenting that and you have no way of knowing it really was. Some of these guys get shocked because it's doing other things. What's persistent V-fib VTAC? Confirmed V-fib, pulsus VTAC. Pulsus means they need CPR, seen any time after the first shock. So anytime you give a shock in a cardiac arrest situation, that can count as your first shock. If you think, I'm going to give an antiarrhythmic, as in this case, Amiodarone, think ALPS. We want to give the study drugs as soon as possible, within 10 minutes or less after arrival. Now, if they have a resuscitation and if it's shocked and you get there and the guy, so like they did in Camus, the guy was in good shape, you just get ready in case he goes back into VFib, because you get it ready to shock again. So after the second shock, you can give the ALPS drug at any point. So you can give the epinephrine or give the ALPS drug back to back with the epinephrine. You can give it in that same sequence if you want to get it in quickly. If VFib, VTAC returns, carry out the full ALPS protocol. You gave syringe 1A and 1B, got pulses, and then it comes back, and then you shock again if it comes back to VFib, and you give the second dose of the second syringe number 2. If it's late occurring, happens when you're in transport, you treat it the same way. Anytime then it's a recurring VFib. The first dose for normal people is the first 2 syringes, 1A and 1B. The second dose is syringe B, syringe 2. Except for little itty-bitty people, not children, but little itty-bitty under 100 kilos, under 80 to 100 kilos. I wouldn't even worry about it. You're not going to see a lot of those. If you've given all the syringes of ALPS drug and they come back and they're still in VFib or recurrent VFib, then you go to magnesium as your alternative antiarrhythmia. You can't use either amiodarone or lidocaine, but you can go to magnesium and additional shocks, more epinephrine, etc. If a syringe is broken or gets broken while you're doing it, that patient, you still have to call in and record that patient, but that patient is automatically taken out of the ALPS protocol, and you can go to your regular protocol and use open label amio or lidocaine, because the patient's out of the study if you can't get the full ALPS treatment. You got to use a ClearLink adapter. We know that. After enrollment, call this number. Document as you will. You document who's monitoring. You're doing very well at the documentation. We have, at least in the cases we've turned in, we've missed one recently because they didn't have the kit. We missed this one because they didn't recognize it, and they thought it was an excluded patient, which is, like I say, too many paramedics enjoying each other's company. And we missed another one because they didn't recognize that it was a potential rock case. So nevertheless, we still put in about 37, 38 cases into the rock study now, the ALPS study. You have to list whether it's your monitor, because we have to upload that CPR process file from that monitor. That's usually taken care of for you. Timestamp, if you can. I know you do it after the fact, but try to timestamp as much as possible the dosing of ALPS drugs. Okay. Quickly, hyporesus. We still are sitting at 4 cases. 4 cases entered. Blunt or penetrating injury, pre-hospital blood pressure of less than or equal to 90 millimeters. The usual suspects, patient over 18 years old and excluding the prisoner's pregnancy, et cetera, et cetera. And also evidence of severe blunt or penetrating head injury, GCS of 8 or less. Also not paralysis, because paralysis is going to give you hypotension from spinal cord injury. You get hypotension not on the basis of hypovolemia. So, what do? You open the kit. So if the patient fits the criteria, so blunt or penetrating injury, blood pressure less than or equal to 90, age greater than 18, and none of the exclusions. Open the kit. And the kit then will identify whether it's a 250, it'll either have 250 cc bags, two 250 cc bags, and a dummy bottle, or a 1,000 cc bag. If it's a 1,000 cc bag, you can bolus up to 2,000 cc's. You open another bag. So if the blood pressure less than 90, bolus up to 1,000 cc's, check. If their blood pressure is still less than 90, you can bolus another one. If it's if the blood pressure is up, is 110 or so, then you just TKO. If it's the 250 cc bag, the blood pressure less than 70, or no radial pulse, bolus 250 cc's, reassess. If it's still less than 70, no radial pulse, bolus another 250. And you can continue doing that if the blood pressure is less than 250. That will require that there be extra bags, and there should be extra bags available for you. But you're always dealing with the 250 cc bag. That's what the hospital will do too. They will only bolus 250 cc bags, assessing that blood pressure too. If you started assessing the patient with no radial pulse, if that's what you're using as your less than 70, continue to do radial pulse. If they're doing blood pressure, use blood pressure. So you just continue your protocol following that arm. Now, getting back to the ALP study, we've got some fairly significant data in our in last year's out-of-hospital cardiac arrest. We're running at about, at least in the area covered by AMR, so most of the county. We haven't been able to marry the CAMUS data and North Country data to it yet. In the area covered by EMS District 2, AMR, we have about 16.8% survival of out-of-hospital cardiac arrest. That means these people leave the hospital in reasonable neurologic condition. That's what successful resuscitation means now. What we appear to be really lacking in this county, and I think it probably accounts for some of the data holes, is that we have very low citizen CPR. If we look through the dispatch stuff, we have about 5% of the people report that they know how to do CPR when they call in with an apparent cardiac arrest. So we're thinking that we need to improve that. We may jump up our survival rate. Our survival rate from primary VFib is somewhere around 35%. And if you look at Seattle, they report, for whatever data mining they do, they report up to about 47%. So we're going to make a push this year and next year and maybe the year after that to improve citizen CPR. And we have to do that by training. So we're looking ahead, and the reason I'm talking to you about this now, we're going to have a meeting right after this, right after PCEP with the trainers from the agencies. I'm going to try to make a push this year to during EMS week, which is in April, which is in May. It's the week of right around the 23rd, 24th. We're going to try to have some mass citizen CPR training, basically just on compression-only CPR. And to do mass training, we're going to get all the agencies together. AMR, it's a national goal for AMR as well, but to do increased citizen CPR. sometime in that week, probably either the Thursday or Friday of that week, I want to have 1 or 2 or 3 places in the county that we will do citizen CPR. To do that, I'm going to need volunteers to man these stations, basically. Now, the week before that, on Friday, I've already arranged with, we have the poster children for high schools with cardiac arrest. It turns out to be Evergreen, that has had 2 successful student resuscitations from VFib with the AED at the high school. But they're interested in us doing. We're going to train all of the seniors and all of the juniors on one day, which is about 800 kids. But we need only to do that with a. How long does it take to train somebody on compression-only CPR? Takes about 2 to 4 minutes on mannequin time, and a brief presentation. You can do, 400 kids with 10 instructors very quickly, very easy. So, more news to come later on. We'll be trotting this out, and we'll need some volunteers, and some of you may even have kids in the Evergreen district. Evergreen wants us to continue teaching all the kids next year, but not on such a mass thing. We'll do freshmen 1 quarter, sophomores 1 quarter, juniors the next quarter. Now, I'm expecting that Vancouver School District will call up and whine and say, hey, what about us? Well, we'll probably have to do them too. This is a good way, get 2,000 or 3,000 kids, 5,000 kids trained a year, and we go out to and get some adults. We get 20,000 to 40,000 people trained in CPR. So, okay. Next month is skills station for the paramedics. It'll be another 12 lead refresher and training. Okay.